Hi everybody, and welcome to our module on autonomic drugs, acetylcholine. So here's our map of the autonomic and somatic nervous systems of the body, and in this module we are going to talk about drugs that activate or block acetylcholine receptors. So let's review where those are found in the body. So some of the most important ones are the muscarinic acetylcholine receptors found in the parasympathetic nervous system, and these are usually at the target organs and they exert the parasympathetic effects like slowing heart rate or activating gut motility. There are also muscarinic acetylcholine receptors at the sweat glands used by the sympathetic nervous system. And then another very important place for acetylcholine receptors is in the somatic skeletal muscle. These are nicotinic receptors found here. Now these are the ones that drive most of the clinical effects of drugs we're going to talk about. There are other acetylcholine nicotinic receptors found in the first synapse for the parasympathetic and sympathetic nervous system, like I've drawn here, and at the adrenal medulla. But these ones over here on the right side of the screen are what drive most of the clinical effects of the drugs. Before we go any further, let me just review a little vocabulary. When we say something is adrenergic, we mean it's related to norepinephrine or epinephrine. So there are adrenergic drugs, and these work on norepinephrine or epinephrine receptors. When we say something is cholinergic, we mean it's related to acetylcholine. So there are cholinergic drugs that work on either muscarinic or nicotinic receptors. And then sometimes we say something is antiadrenergic or anticholinergic, and that means it's a blocker of norepinephrine or epinephrine receptors, or in the case of anticholinergic, it blocks acetylcholine. So make sure you understand that nomenclature as we go forward. So let's talk about what would happen if you activated or blocked certain acetylcholine receptors. First we'll talk about the muscarinic ones. If you activate muscarinic receptors generally in the body through use of a drug, you would get all the effects of the parasympathetic nervous system plus sweat, because sweat is also a muscarinic acetylcholine receptor. If you were to block muscarinic receptors, you would block all the effects of the parasympathetic system, plus there would be no sweat. And keep in mind that sweat is the major way by which the body dissipates heat. So if you cannot sweat, your temperature will rise, and when your temperature rises, it will cause your skin to flush. So blockade of muscarinic receptors is associated with high body temperature and skin flushing by this mechanism. Nicotinic receptors are a little bit different. If you block nicotinic receptors, the primary effect is to paralyze the body because of nicotinic receptors found at skeletal muscle. And then there really aren't a lot of clinically important nicotinic agonists, so you don't need to worry too much about those. But in terms of blockers, the main clinical effect is driven by paralysis, and that's where they're used. All right, let's talk in a little more detail about what happens if you activate muscarinic receptors in the body, because this will be important when we try to understand how these drugs are used. If you activate muscarinic receptors in visceral smooth muscle, you will increase GI motility. And the symptoms these cause in a patient are nausea and vomiting, and also cramps and diarrhea. These are symptoms of excess GI motility. If you activate muscarinic receptors in secretory glands, you get sweating, salivation, and lacrimation. In the bladder, muscarinic receptors are responsible for detrusor smooth muscle contraction, so this is what allows you to urinate. So activating the muscarinic system in the bladder helps people urinate, and if you block it, they won't be able to urinate, and that's one of the side effects of antimuscarinic drugs. In the heart, muscarinic receptor activation leads to decreased contractility by allowing less calcium into the heart cells, and decreased heart rate by allowing less calcium into the SA and AV nodes. In the lungs, muscarinic activation leads to bronchoconstriction, so the symptoms that patients will develop are things like wheezing and dyspnea, or if they have asthma or COPD, you can see a flare of these symptoms. Endothelial cells have a special mechanism by which they are affected when muscarinic systems are activated. So there's no direct effect of muscarinic receptors on vascular smooth muscle to cause vasodilation or vasoconstriction. However, muscarinic receptors can indirectly stimulate nitric oxide release, and nitric oxide, you may know, is a vasodilator. It activates guanylate cyclase, it leads to less calcium into vascular smooth muscle, and the result is vasodilation. So the net effect of all this is that activating muscarinic receptors can lead to lower blood pressure, but it is an indirect effect through nitric oxide, and it's high yield to know that for your boards. So let's talk about some specific drugs that are acetylcholine agonists. So bethanechol is a drug that can be used to activate the bowel or bladder. It's really not used very often, but in theory you can use it if someone has an ileus, which means their GI tract is paralyzed, or if they have urinary retention. Carbachol and pilocarpine are drugs that are sometimes used by ophthalmologists to lower intraocular pressure. And then finally, methacholine is a drug used by pulmonologists. They have patients inhale it, and they monitor them for bronchoconstriction. If they develop significant bronchoconstriction, it can be a way to diagnose that someone has reactive airway disease and something like asthma. And these are all related to the properties of these drugs in activating acetylcholine muscarinic receptors. Acetylcholine esterase inhibitors also increase the activity of acetylcholine receptors. However, they do so indirectly in contrast to the acetylcholine agonists. So the way these drugs work is they inhibit the enzyme acetylcholine esterase, which breaks down acetylcholine. This will increase the amount of acetylcholine in the synapse and indirectly raise the activity level of acetylcholine receptors. Drugs in this class are shown on this slide. They include neostigmine, which is sometimes used for ileus or urinary retention, just like bethanechol. In addition, the muscle disease myasthenia gravis, which we'll talk about in a minute, results from insufficient activity of acetylcholine receptors. So if you boost acetylcholine receptor activity, that can help. Pyridostigmine and edrophonium are also used in myasthenia gravis. Physostigmine is sometimes used in anticholinergic toxicity. We'll talk about this later, but if a patient is administered a drug like atropine that blocks cholinergic receptors and they overdose on it, you can give physostigmine to boost the levels of acetylcholine and overcome the anticholinergic drug toxicity. And then finally, donepezil is a drug that works on acetylcholine esterase in the central nervous system, and it boosts CNS acetylcholine levels, and this is sometimes used in Alzheimer's disease. Let's talk about myasthenia gravis briefly. It's an autoimmune disease where antibodies block the acetylcholine receptors. Nicotinic receptors in muscles are what are primarily affected clinically so that patients become weak. The classic signs and symptoms are eye problems, so the muscles of the eyes are particularly prone and patients will have diplopia and trouble moving their eyes. They can also have trouble chewing, talking, or swallowing, all from muscular weakness. A classic finding is what's called fatigability, and it's very important you understand this concept. With repetitive movements of the muscles, the levels of acetylcholine begin to fall. The presynaptic neuron can't keep producing more acetylcholine, and this will cause the problem to get worse as patients repeat muscle activities. And you can treat it with all the drugs we talked about on the last slide, neostigmine, pyridostigmine, edrophonium. It's also treated with immunosuppressants to try and block the antibody production. People with myasthenia gravis frequently suffer from exacerbations. They'll be stable for a while on a drug regimen and then they'll start to get weaker than usual. And this can happen for two reasons. The first reason is because they're on an insufficient dose of their acetylcholine esterase inhibitor. But the second reason is because they're on too much acetylcholine esterase inhibitor. This is called cholinergic crisis. What's happened is the drug has flooded the muscle with acetylcholine and the muscle has become refractory. The way you sort this out at the bedside is something called the Tensilon test. You give edrophonium. This is an acetylcholine esterase inhibitor. This will increase the amount of acetylcholine in the synaptic cleft. If the muscle function gets better, it means the patient needs a higher dose of their acetylcholine esterase inhibitor. If the muscle function doesn't improve, it means they need a lower dose. The edrophonium test helps you sort out whether more acetylcholine or less acetylcholine is the right answer to the patient's problem. So it's very important you understand this mechanism because you're often asked about exacerbations of myasthenia gravis on your boards. Let's talk about Lamberton-Eaton syndrome. This is a syndrome that's similar to myasthenia gravis in that it involves weakness due to dysfunction of the nicotinic systems at somatic muscles. However, it's caused by a different mechanism than myasthenia gravis. This is a paraneoplastic syndrome and it classically occurs in a setting of small cell lung cancer. Patients will develop muscle weakness similar to myasthenia gravis. In this case, however, the antibodies are directed against presynaptic calcium channels, not against the acetylcholine receptors. This prevents the release of acetylcholine from the presynaptic neuron. As a result, if you do an edrophonium test and you inhibit acetylcholine esterase, it won't help because there's no acetylcholine in the synapse for you to increase by blocking acetylcholine esterase. So the edrophonium test produces no improvement in Lamberton-Eaton syndrome. A word about COPD and peptic ulcers. Any cholinergic medication can worsen these two conditions. Direct acetylcholine agonists or indirect acetylcholine esterase inhibitors both can cause your COPD or peptic ulcers to get worse. In COPD, they can cause bronchoconstriction and the COPD can flare. In peptic ulcer disease, they increase the amount of gastric acid production, which can lead to ulcers. So you should be aware of both of these side effects. So now let's talk about organophosphate poisoning and consider the following clinical scenario. A 44-year-old farmer presents to the emergency room with difficulty breathing. There is audible wheezing. He also reports diarrhea and unintentional loss of urine. He appears agitated. On exam, he has pinpoint pupils. He is sweaty, drooling, and his eyes are watery. His pulse is 30. So this is a classic clinical scenario for organophosphate poisoning, and I've underlined some of the key symptoms, and we'll talk about those in the next few slides. So organophosphates are found in insecticides, and farmers can get exposed if they get the insecticide on their skin and it gets absorbed by the body. These compounds irreversibly block acetylcholine esterase, and as a result they put all acetylcholine synapses into overdrive. The different symptoms relate to the different activity of the acetylcholine receptors. So the muscarinic receptors, when they go into overdrive, cause diarrhea from stimulation of the GI tract, urination, bronchospasm. They slow the heart rate, giving bradycardia. They cause salivation, which is the drool he had, and they cause lacrimation, which are the tears he had. Activation of the nicotinic receptors by acetylcholine in overdrive causes muscle fasciculations, and activation of central nervous system or brain acetylcholine synapses leads to confusion, lethargy, and sometimes seizures. There are two drugs used to treat this condition. The first one is atropine, which we'll talk about in a few slides. It's a muscarinic antagonist. And the second one is called pralidoxime, which regenerates acetylcholine esterase. So just keep in mind that if you see a board question or a test question about a farmer who is confused, sweating with pinpoint pupils, this should set off red flags for you that you are likely looking at organophosphate poisoning, a very high yield condition to know about for your board exams. So everything I've talked to up until now has been about drugs that activate acetylcholine receptors. Now we're going to talk about drugs that block the effects of acetylcholine at receptor sites. And first let's talk generally about what a drug that blocks acetylcholine receptors might do to the body. Well, you would get dry skin if you blocked acetylcholine receptors in the sweat glands because remember, the sympathetic nervous system uses acetylcholine to stimulate sweating. When you can't sweat, you've lost one of your main mechanisms to dissipate heat. So as a result, you would get very warm. You'd have hyperthermia and an increased temperature. And this is a direct result of losing your sweat. When your body temperature goes up and you can't sweat, your skin will begin to vasodilate in response to the hyperthermia. This is a local reaction and this will make you flushed. So a patient who has dry skin with no sweat, but who is hot and flushed, should suggest to you that this may be a person who's got their acetylcholine receptors blocked. Let's talk about other effects you would see. There would be dry mouth and dry eyes because the patient can't lacrimate or salivate. You would see dilated pupils if acetylcholine receptors get blocked, and blockade of acetylcholine receptors can trigger acute angle closure glaucoma by dilating the pupil and other effects on the eyes. You would see delirium because of blockade of brain acetylcholine esterase systems. And some people remember this through the saying, red as a beet, dry as a bone, blind as a bat, mad as a hatter, and hot as a hare. Those are all the symptoms of blockade of the acetylcholine esterase system. So now let's talk about some specific drugs that do these kind of things when we want to do it to help a patient. So the drugs on this slide are all muscarinic blockers. The first two are homatropine and tropicamide, and these are ophthalmology drugs that dilate the pupil. Benztropine and trihexylphenadil are sometimes used in Parkinson. Scopolamine is given as a patch that you put behind your ear if you're going to be on a ship for a long time, and it prevents motion sickness. Ipratropium and tiotropium are inhalers for COPD, so they lead to bronchodilation. Oxybutynin is given to women who have bladder spasms and urinary incontinence. And glycopyrrolate is given to dry up airway secretions. Sometimes we're going to do certain surgical procedures where we want the airway to be free of secretions. Let's talk about motion sickness in a little more detail. If you go on a cruise ship, for example, after a few days you may find yourself feeling nauseous and vomiting, and this is called motion sickness, and this results from overstimulation of the M1 muscarinic receptors and the H1 histamine receptors, and that leads to the nausea and vomiting. The scopolamine patch, which is a small patch you can place behind your ear, blocks the M1 receptors, and this helps alleviate motion sickness. There are also antihistamines that help. Meclizine is sold as Antivert, and dimenhydrinate is sold as Dramamine, and these also help prevent motion sickness. The major side effect of these drugs is that they can be sedating. That's what happens with a lot of antihistamines. Side effects of the scopolamine patch are dry mouth, urinary retention, and constipation, and these should all make sense to you. That results from blockade of systemic muscarinic receptors. Now let's talk about a very important muscarinic blocker, and that is atropine. So consider the following clinical scenario. A 50-year-old man feels dizzy after a central line is placed in his left jugular vein. His EKG is shown below. So let's look at this EKG. There's a P wave here, and then a PR interval and a QRS right here. Then there's another P wave and a longer PR interval and then a QRS. And then there's a P wave, and there is no QRS until we get another P wave. So he has developed Mobitz type 1 block or Wenke block heart block, and that's what's making him dizzy. He developed this as a result of the central line that's placed. It can cause something called a vagal reaction, where you get heavy output from the vagal nerve that slows conduction in the heart. So he's given atropine and his dizziness resolves as EKG tracing converts to the tracing below. So down here we've got P wave, QRS, P wave, QRS. There are no missing QRSs. He's gone back into a normal sinus rhythm. However, later that night he has pelvic discomfort and is unable to urinate. So this is a very common clinical scenario, and what's happened to this man is you've blocked his muscarinic receptors, which was helpful to pick up his heart rate and fix his dizziness, but it's now made him unable to pee. So atropine is a muscarinic antagonist. It's used for bradycardia and also for pupil dilation sometimes. It's part of the ACLS algorithm, and that's the algorithm we follow when patients have a cardiac arrest. One of the steps in that algorithm is to consider administering a milligram of atropine to try and speed up the heart rate. The toxicity from atropine is all toxicity you would expect from blocking muscarinic receptors. You get very hot because you can't sweat. You get dry skin, dry mouth, constipation, urinary retention, and especially in the elderly, blockade of central nervous system acetylcholine receptors can cause confusion. And the treatment is to inhibit acetylcholinesterase with visostigmine, and this produces more acetylcholine in the synaptic cleft and will hopefully overwhelm the effects of atropine. It's high yield to remember that atropine is contraindicated in glaucoma. It decreases the outflow of fluid in the eye chambers, and this can lead to sudden eye pain and halos. So if you're ever told that that happens to someone after atropine administration, this is why. There's a condition related to atropine overdose called Gardner's mydriasis. There's something called the Jimson weed, and it produces a toxin that works very similarly to atropine. It has anticholinergic properties. So a Gardner who's exposed to this will have dilated pupils and tachycardia and hypertension and dry mouth. And just like atropine side effects, it's treated with visostigmine. So there are three conditions where you get poisoning of acetylcholine synapses. The first one is botulism, the second one is atropine overdose, and the third one is organophosphate poisoning. And they can all start to get confused in your mind. I know I sometimes struggle to keep them straight. So let me just review the three of them together and give you some tips as to how to sort them out, especially if you see them in board questions. Botulism toxin produces nicotinic and muscarinic blockade by blocking acetylcholine output from the presynaptic neuron. The key here is paralysis. That's what dominates the clinical picture. It's a descending paralysis that starts at the head and neck and the cranial nerves and goes down. Patients have trouble speaking and swallowing, and there's sometimes often GI symptoms associated with it, especially in a board question, because people get sick from eating contaminated food. Atropine overdose, on the other hand, is essentially muscarinic blockade, so there are usually no muscle effects. So you won't see too much fasciculations or paralysis. You will see symptoms related to the atropine itself. And then finally, organophosphate poisoning is nicotinic and muscarinic activation, not blockade. So you can see weakness from depolarizing blockade, but that usually has a lot of fasciculations. And you can see stimulation of the muscarinic receptors, which produces meiosis, bradycardia, tears, and sweats. Keep in mind the pupils and the heart. Those are good telltale systems. If you see meiosis and bradycardia, you have activation of acetylcholine synapses. If you see dilated pupils and tachycardia, you have blockade of muscarinic receptors, as in atropine overdose. And that's the way I often keep them straight. When I start to get confused, I look at the question and see what's happening in the eyes, what's happening in the heart. If the heart rate is fast, it's atropine. If the heart rate is slow, it's organophosphates. You can do the same thing for the eye findings. There are many drugs that have what we call anticholinergic side effects, and these are side effects that look just like the effects of atropine. Tricyclic antidepressants can have anticholinergic side effects. First-generation antihistamines like chlorpheniramine and diphenhydramine, some antipsychotics, and some anti-Parkinsons. So when we're talking about drugs, we'll often say, well, that drug has anticholinergic side effects. And what we mean is it does things like what atropine does, which is make your mouth dry and make it hard for you to urinate and make you constipated. So these are things like pupil dilation, dry mouth, constipation, urinary retention, sedation. These are side effects of many drugs, and we call them anticholinergic side effects. Urinary retention is a common side effect of anticholinergic drugs, and make sure you keep that in mind. It's more common with older men who have benign prostatic hypertrophy. They have trouble urinating at baseline, so if you give them a drug, it will get worse. Watch for this clinically and also in board questions after patients have had atropine or some of those other drugs I mentioned with anticholinergic side effects. Some that stick out in my mind that I always keep mindful of are drugs like tricyclic antidepressants or Haldol. It's sometimes given to an older man for sedation when they've become agitated, and then they will have difficulty urinating from the anticholinergic side effect. The last thing I just want to mention in this module are nicotinic blockers. There are drugs that block the nicotinic receptors. They're used to paralyze the body in anesthesia, and we talk about those separately in a module on neuromuscular blockers under anesthesia. And that concludes our module on autonomic drugs, acetylcholine.